All right, welcome everybody. Thank you for all who are joining us today. Our Division 38 Integrated Primary Care Interest Group meeting every few months. We have these meetings that are open to all the members. Today's a special because we have actually made it available to non-members as well, just so that y'all can learn about the great things that we're doing. But before anything, thank you for joining us for the IPC Chair Series, Ethics and Integrated Primary Care, hosted by the Society's Integrated Primary Care Interest Group. I'm Yahaira Johnson Esparza, the chair of the IPCIG. My co-chairs will introduce themselves in a bit. Before we begin, we do have a few things to share. First, this is an all Society for Health Psychology virtual presentation. It's offered as a free benefit of membership in the Society for Health Psychology. Please invite your colleagues and students to join to ensure unlimited access to future presentations and other society benefits. Visit our website at societyforhealthpsychology.org for more information. This event is being recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. Questions will be taken at the end of the presentation. You may submit them via the chat feature during the presentation. We will call on you at the end of the presentation to unmute and ask your question. And now we'll go ahead and begin our meeting for today. So really, many of you are here for the ethics and IPC talk that Dr. Gibson Lopez will be giving in a little bit, but we did want to introduce you to IPCIG leadership. Like I said, I'm Yahaira Johnson Esparza. And then we should have our ECP associate chairs. If you wouldn't mind unmuting yourself to just introduce yourselves, it would be great.
Hi, I'm Dr. Brittany Houston, and I'm one of the early career professional associate chairs for the IPCIG.
And I don't know if Dr. Williamson is on. I didn't see.
I'm here. Can you hear me?
Yeah.
Okay, good. Hi, I'm Meredith Williamson, and I'm the other CP.
And thank you. We do have a student representative, Noel Mastrelli. I don't think she's on the call. She is, great for her. She's moving on to postdoc. So we will be looking for a new student rep, any students out there, or if you know of any students, please send them our way. Send us an email. We are looking for a student who is really interested in IPC to help us with these efforts. Quick update on the various subcommittees. We won't go into these too much, but I'm happy to share the slides, and you'll have some contact information in these slides if you want to reach out to any of the leads. We have the IPC introductory curriculum subcommittee that has been led by Dr. Ward Zimmerman. This is the link where you can find that curriculum. We have the IPC Education and Consultation Series. Our IPCIG lead is Dr. Ellen Joseph. It is a collaboration with the SDM IPC SIG, led by Philip Pfizer, and the CFHA Reg, led by Dr. Jennifer Funderburk. They've had great talks. They had Dr. Leslie Manson and Dr. David Bellman present on topics related to quality metrics and how to use your EHR when it comes to research. We have another group, the IPC Practice Management. It's a great opportunity to get mentorship, build your networks, to help in all things practice management in IPC. We have Dr. Obaid, who's our liaison, Dr. Stacey Obaid, our liaison for interdivisional collaboration around IPC issues. That is one area where we also try to be active. And our Health, Equity, and Diversity Subcommittee, that's actually also led by Dr. Gibson Lopez, who you'll be hearing from today. And finally, we are looking for folks who can help us with website and social media. I think the three of us, Dr. Williamson, Dr. Houston, and myself, are not social media, so we are looking, at least I'm assuming we're not, so we're looking for folks who can help us out with that. Please feel free to reach out. And I'll hand it off to Dr. Houston.
Hi there. I'm not going to take up too much of your time, but just wanted to talk to you a little bit about how the IPCIG Chairs webinar came about. Dr. Johnson Esparza and I did a presentation at the last APA conference about integrated care, specifically the primary care behavioral health model, and gathered some data about current conceptions about myths with integrated primary care. And from that particular presentation, we thought it'd be a good idea to focus on not only the myths, but talking more about the psychologist's identity and how they adjust to the primary care culture and integrate as part of the team. And so that's where we came up with these 4 topics. And so, of course, today we're going to be hearing from Dr. Gabriela Gibson Lopez on ethics in integrated primary care. In April, we're going to be hearing about population health and how adjusting to that culture is important when working as a psychologist in integrated primary care by Dr. Mark Vogel. In July, we'll be hearing from Drs. David Bauman and Bridget Beachy on working in integrated primary care teams. And then we'll finish off the year in October talking about the educator role that the psychologist plays in integrated primary care teams. And so we will be blasting that information over the listserv. Future webinars will hopefully be available for CEs. We're working on that currently. And then as Dr. Johnson Esparza mentioned, those will be only available to division members after this presentation as part of the member benefits. So without further ado, I'm going to turn it over to our guest speaker today, Dr. Gabriela Gibson Lopez, to talk about ethics in primary care.
All right. It's not letting me share screen. Let me try again. Here it goes. Okay. Can you guys see my slides okay? Oh, actually, this is the end. Sorry. That's not where we're starting. My bad. All right, so here we go. I'm Dr. Gabriela Gibson Lopez. I'm a licensed clinical health psychologist. Today we will be talking about ethics in primary care. There's always a lot to cover and never enough time, so let's just jump right in. Objectives. I'm hoping that by the end of this presentation, you will be able to identify common ethical challenges, analyze the APA ethical code to help assist with resolving some of these challenges, and then describe ethical decision-making models and interdisciplinary guidelines. I also want to point out that within integrated primary care, there are different models of behavioral health integration. This presentation will focus on the PCBH model of integration. All right, so moving forward with a brief review of the APA ethics code. Brief is a key word. So the APA ethics code breaks down into 3 components. It starts off with an introduction. Within the introduction, you will find the intent of the code, how it's organized, procedural considerations, and scope of application. And after that, you will find the preamble and the 5 general principles. These principles are aspirational goals to help guide psychologists towards the highest level or highest ideals of psychology. And then lastly, you will find those specific ethical standards, which are those enforceable rules of conduct. Doing a brief review, let's do a brief review of those 5 general principles, starting with the first, which is beneficence and non-maleficence. Now, this principle states that psychologists strive to benefit those with whom they work and take care to do no harm. When conflicts do arise, they attempt to resolve it in a responsible way that avoids or minimizes harm. The second principle of fidelity and responsibility states that psychologists establish relationships of trust with those that they work. and that they're also aware of their professional responsibilities. They uphold professional standards of conduct. They clarify their professional roles and obligations, and are concerned about the ethical compliance and professional conduct of their colleagues. The principle of integrity in general states that psychologists seek to promote accuracy, honesty, and truthfulness in the science, teaching, and practice of psychology. The fourth principle of justice states that psychologists recognize the fairness and justice entitle all persons to access to and benefit from the contributions of psychology. And that they also exercise reasonable judgment and take precautions to ensure that their potential biases and the boundaries of the competence and the limitations of their expertise do not lead to or condone to unjust practices. And last but not least, the fifth principle of respect for people's rights and dignity. This principle states that psychologists respect the dignity and worth of all people and the rights of individuals to privacy, confidentiality, and self-determination. Now here you will see the different sections of the ethical standards. Within each section, you will find more specific codes. And so we won't dive deeply into all of these. We will analyze a little bit more deeply some of them. But essentially what I want to point out are some characteristics of the code that are important to know. The code was written broadly, and this was done so that psychologists can apply it in varied roles. And of course, the application is also going to vary depending on the context. The code is also not exhaustive, and it's not intended to be a basis of civil liability. It does use modifiers, so words like reasonably, appropriate, potentially, in some of the standards. And this was done in hopes that it will allow for the use of professional judgment, and also to help ensure that it is applied across a variety of activities, and that it will guard against a set of rigid rules. Now, as I mentioned, context is important. So let's look a little bit more into the context of PCBH. So here you see a table that describes the differences between the PCBH model and specialty mental health across a variety of dimensions, and also different types of ethical quandaries or challenges that can arise within each dimension. So one of the most challenging pieces with regards to applying the ethical code in the context of primary care is that the mental health workforce is still being traditionally trained to work in specialty mental health settings. And of course, so when they arrive to the PCBH setting, not only are they having to learn about the primary culture and adapt to it, they are also realizing that they face very unique circumstances that, one, are not always addressed by their ethical code, but also when they consult it, sometimes the setting in which they're practicing makes it really hard for them to abide and adhere to these ethical standards. And so that, of course, leaves a very challenging situation and leaves behavioral health providers in situations where they are needing more guidance to resolve some of these unique challenges. So let's look at those challenges that we see in the literature. Some of the most common ones cited in the literature pertain to issues with regards to informed consent, confidentiality and privacy, complex relationships, competence, and scope of practice. Now, with regards to informed consent, the concern of blanket consents is something that is cited in the literature. In primary care, the standard of care is to provide that consent at the initial point of contact when that person is first establishing care at that clinic. And in clinics that integrated behavioral health services are provided, it is often discouraged to provide a second traditionally written behavioral health informed consent. Because those behavioral health services are consultative, and two, they are provided in conjunction with or directly in that primary care clinic. Some others also argue that providing a different informed consent specifically for behavioral health services can further stigmatize that care. However, this idea of blanket consents is also countered in the literature by the idea that informed consent is actually an ongoing process that should be revisited throughout the treatment process, and is something that is not just done at that initial kind of paperwork phase. Another challenge is the idea or the concern of patient health literacy as it relates to blanket consents. So we know that the level of health literacy that a patient has can impact their ability to really understand the complexities of team-based care and not really be able to make a truly informed decision. And then there is the concern of coercion that also comes up in the literature. And this pertains essentially to the idea that PCPs can sometimes be very passionate about the services that they think their patients need. And within PCBH, there are warm handoffs, and that immediate access to those services can sometimes leave little room for the patient to decline services. And then, of course, lastly, an important component of the informed consent process is clarifying your role. We also know that role expectations can be influenced by different factors, including a patient's previous experience with behavioral health services, and also how the BHC is marketed in the clinic. And so if this is not done adequately, then of course that can leave the patient to consenting essentially to like false expectations. So let's look at what the APA ethical code says with regards to informed consent. So it states that when psychologists engage in research, treatment, or consultation services, that we obtain and document that informed consent, whether it's written or oral, and that it's done in a language that the patient understands, and that we provide the patient opportunity to ask questions and receive answers. So, of course, what is the BHC to do then, right? So these are some recommendations that are in the literature that can help individuals navigate some of these challenges that pertain to informed consent. So yes, it is important to put that information, that informed consent, in that initial patient packet. And also, it's important to revisit that conversation throughout the treatment process and document any changes that could occur. When this conversation does take place, it's important to have it be patient-centered and done, of course, with appropriate level of health literacy and cultural competency, and also done in a way that patients can truly understand what team-based care is, that they can ask questions, and allow them the opportunity to either opt in or opt out. And if they choose to seek care elsewhere, that they receive help in connecting somewhere else if they want to do that. Now, for a BHC, a great opportunity to revisit that conversation of informed consent is going to be at that point where you receive that warm handoff. And so this highlights the importance of having a really sound behavioral health introduction that includes those components. Another interesting thing that's also important to consider is sometimes when you receive that warm handoff, you see it's a patient that maybe is very emotionally distressed, And so sometimes we know that that can impact someone's ability to make an informed decision if their emotions are running really high. And so something to consider is perhaps doing a meet and greet, an introduction, and maybe discussing a time to schedule a visit or making a plan to catch them at that next appointment if that's the case. Of course, with regards to role expectations, it's going to be important that team members of the primary care team or members of the primary care team are trained to not only introduce the behavioral health services, but also the BHC role on the care team. And then be mindful of how they're advertised on brochures, on websites. And then if you're a psychologist or a BHC in a situation where you are building an integrated primary care practice from the ground up, it's important to have access to legal counsel or at least be familiar with the federal state laws when you're developing a consent form. So now let's look at those issues that relate to or challenges that relate to issues of confidentiality and privacy. Now in primary care, care is longitudinal, which of course can result in challenging situations. In situations, say, where a BHC sees a patient that maybe has extensive history in that clinic. Breaches of confidentiality are at greater risk when that patient with that extensive history maybe presents to care with another person. Of course, PCBH, we know, and in other kind of team-based practices has very complex communication systems that often patients are not aware of or truly fully understand. So patients maybe don't know what and how much information is shared in the PCP appointment will be shared with the BHC and vice versa. And then, of course, the use of shared health records further opens the door to confidential information being shared with other members of the primary care team or even just the general healthcare system. And then there's a notion that, BHC visits, of course, will generate some sensitive information. And of course, learning to write appropriate progress notes versus psychotherapy notes can be challenging for those BHCs who maybe are transitioning from specialty mental health. Primary care also provides whole family care, which means that essentially multiple members of a family will often present to the same clinic and often see the same provider. So of course, as a BHC in this clinic, you will often receive referrals to see multiple members of the same family, which of course will pose issues related to confidentiality and privacy. Primary care is also team-based. And so it's not unusual that members of the primary care team will seek their colleagues for care and guidance. And so this, of course, can add, to add challenges related to confidentiality and privacy. And then there's always those physical characteristics of the clinic space. As we know, primary care is a busy and fast-paced environment. So oftentimes you have multiple providers in a workroom, and there's constantly information being shared. You are trying to catch the PCP, or the PCP is trying to catch you for a warm handoff or to share information, and the hallway maybe is the first place where you catch them and that information is being shared. And sometimes primary care clinics are not constructed very well, and there's very thin walls, and sometimes you can hear a lot of things that are being said in the room right next to you. So this adds another kind of challenge with regards to issues of confidentiality and privacy. So let's look at what the code says. The Code of Ethics states that psychologists have an obligation to protect confidential information, discuss the limits of confidentiality, and discuss confidential information obtained in their work only for appropriate professional purposes and with persons clearly concerned for such matters. It also states that in the written and oral documentation of consultations, they include only information that is relevant. So recommendations for navigating some of these challenges that relate to issues of confidentiality and privacy. Similar to the previous slide, putting all that information regarding authorization of release of information and privacy policies in that initial patient packet, revisiting and documenting throughout the treatment process if necessary. Again, having a very sound, solid BHC introduction that highlights the type of communication that will occur between you and the PCP and or other members of the primary care team, and also that you will be documenting in that same health record, which means that other people will have access to it. Sometimes engaging in more patient-centered communication patient-centered documentation could be helpful. So engaging your patient in the documentation process could also help with some of that. When you are, with regards to patients who have those long histories in that clinic, seeing them alone first, especially when they present accompanied by others, could be helpful. In that conversation, you can sort of establish what you know and engage in a discussion about what will be shared and if that person will be in that room. With regards to seeing members of the same family or colleagues, of course, using careful ethical decision-making to determine if unbiased consultation can be provided is going to be important. There are also options, right? If you are able to have BHCs see the different BHCs see separate members of the family, that would be great. Maybe even considering a family consultation visit if appropriate, and engaging in a discussion about maybe being referred to outside therapy can also be helpful. In situations where you just have to be in this situation, having transparent communication about the challenges that can arise when you are in this situation is going to be helpful. And then documenting, of course, that conversation as well as any decisions that are made regarding the treatment. In regards to, again, the shared health record, learning to document and teaching those that you supervise to document in a shared health record will be important. With regards to seeing colleagues, sometimes exploring the the electronic medical record system and security options could be important or could be helpful. I know some EMRs offer options such as breaking the glass or security audits that track when and who access the chart are options that could be put in place to enhance privacy and confidentiality in these situations. And then, of course, being mindful of your surroundings when discussing patient information. Now, moving forward to multiple and complex relationships. As previously mentioned, certain characteristics of primary care, such as the fact that it is team-based, that they provide whole family care, can raise ethical issues that pertain not only to confidentiality and privacy, but also multiple and complex relationships. Additionally, sometimes you may also be put in a situation where you are asked not only to see the colleague, but maybe a member of their family as well. Also, in places where in primary care clinics where integrated behavioral health is provided, oftentimes it is in settings or in clinics that are located in a rural setting, or often they are FQHCs, federally qualified health centers. And what we know about FQHCs and even rural settings is that there are limited referral options. And more specifically with FQHC, sometimes they provide care to people who are underinsured, so they have different barriers or additional barriers to accessing care. And so when you have limited referral options, sometimes the most ethical thing to do really is to engage in that multiple complex relationship, because maybe it's rule setting, or because there are financial barriers or language preferences. But let's look at what the APA code says with regards to multiple or complex relationships. First and foremost, the code defines a multiple relationship as one that occurs when a psychologist is in a professional role with someone and at the same time is in another role with the same person, or is in a relationship with a person closely associated with or related to the person with whom the psychologist has a professional relationship with. And the code essentially states that a psychologist should refrain from entering into a multiple relationship, especially if it could impair their objectivity, their competence, or their effectiveness, or of course, when there are risks with regards to exploitation or harm. Another standard, that is relevant with regards to these type of issues in primary care or challenges is a standard that involves therapy with couples or families. So the code for these situations states that psychologists agree to provide services. However, they take reasonable steps to clarify at the start which of the individuals are clients or patients and the relationship that they will have with each of the parties. Now, I do want to point that, as you can see, this standard is written under the assumption that family members are seeking care together. Now, that could often be the case in specialty mental health. However, in an integrated primary care clinic or just in primary care, the most common situation is that family members will be seeking care independently. And then the BHC later learns that they are related, connected, involved. And so, of course, when BHC then consults their code and runs into this, it could be challenging to not know how to navigate that situation that is unique to primary care. So some recommendations. When possible, consider taking steps to avoid treating colleagues, of course, except in the case of a crisis. Now, however, in the literature, it states that sometimes the BHC is viewed as a caretaker of the primary care team. So that means that assisting members of the primary care team, perhaps on an infrequent basis and with more minor concerns, can actually be healthy. However, if this is the case, it's going to be important to set boundaries around these conversations, providing education to the team about your role with regards to boundaries. So considering, is this a colleague who comes to you periodically, or is this a colleague who comes to you all the time during lunch? Are they seeking just tips and tricks to help their kids sleep, or are they delving deep into some of their marital issues? These are some of the things that you have to consider in this situation and set some boundaries. Of course, as previously mentioned, when you are seeing members of the same family, consider, again, assigning a different BHC to each member of the family. Again, having transparent communication and transparent documentation, and then offering referrals when possible to either specialty mental health or to EAP programs for colleagues. And moving on to challenges with regards to competence and scope of practice. So one of the biggest ones that is cited in the literature is that there are no broadly accepted guidelines or universal standards for BHC competence. This does not mean that there are no outlined competencies or clinical practice management skills. There are different people have put out different competencies and skills that are needed to work as an effective BHC. But there is not one set that is broadly accepted. One of the most frequently cited competencies are the 6 core competency dimensions that are proposed by Robinson and Ryder. You can refer to the newest edition of the Integrated Primary Care book to learn more about those competencies. Now, an additional challenge that comes up in the literature with regards to competence and scope of practice, of course, is the growing workforce needs. Lots of places are moving towards integration in a very rapid fashion. They are onboarding people again. Most mental health providers are being trained traditionally for specialty mental health settings. And so they are lacking some competence. And sometimes these individuals are then put in situations where they then have to supervise others in this setting. And of course, an additional challenge to this is that there is no regulated approach to clinical supervision within PCBH. And so we know that the PCBH setting and the primary care setting gives rise to lots of unique ethical challenges. And so it's important that the BHC has competence, especially when they are supervising others in that role. To help not only provide care, but also help them navigate these challenges that will arise as well. So let's look at what the code states. So the code states that when we provide services, teach, or do research, we stay only within the boundaries of our competence. That is based on the education, training, supervised experience, consultation, study, or professional experience. However, it also states that in situations where psychologists have tried or have provided services, or where psychologists have to provide services involving populations, areas, techniques, or technologies that are new to them, or when psychologists are asked to provide services to individuals for whom appropriate mental health services are not available and for which they lack that competence, or in those emergent areas such as PCBH in which generally recognized standards for training do not yet exist, psychologists make a reasonable effort to obtain the competence required by using relevant research, training, supervised experience, consultation, or study. So it is within our ethical obligation to recognize what we know, what we don't know, and to fill those competency gaps that we've identified. So some recommendations. When working in an integrated primary care clinic, it is essential that BHCs keep their scope of practice or scope of care as broad as possible within the limits of their training and experience, and to be able to determine what those gaps are so that they can increase their scope and their competency. Because the more of a generalist that the BHC is, the more of a team player they will be. Additionally, when BHC has the appropriate training and experience in this area of practice, they are more likely to succeed and more likely to help rather than harm the patients that they're working with. So here you'll find some resources specifically for PCBH training. There is a lot out there. These are just some examples. There are some links on there that you can access. We won't spend too much time on this. So moving forward, as previously mentioned, it's important for individuals to turn to their discipline-specific ethical code for guidance and to learn how to analyze it critically and implement it when possible. However, in the integrated primary care context, again, that can leave people who are turning to the ethical code feeling like the standards make it difficult for them to adhere to it given the context, or they're just not receiving that clear, specific guidance that they want. It's important to know that there are other proposed models of ethical guidance out there in the literature. So we'll do a brief review of what those are. First, There is the 4-box method. This was proposed by Runyon and colleagues. It has been adapted specifically for the PCBH model. And essentially what the authors argue is that a lot of these ethical issues that arise aren't really ethical dilemmas. And in fact, they are related to issues of communication or knowledge or resource deficit. And so they provide this step-wide method for determining if that ethical dilemma is due to a communication issue, a knowledge or resource deficit, or an actual ethical issue. And if that ethical dilemma is an actual ethical issues, they provide guidance for the BHC to then move to the appropriate ethical principle to guide their decision making. There's also this other model that was proposed by Kanzler and colleagues to help individuals resolve these ethical dilemmas in primary care, integrated primary care. And although these are presented, as you see, in a sequence, the authors state that they're nonlinear and they're actually fluid. And so some of the things to consider when resolving ethical dilemmas with a specific model. So considering your context, consulting your ethics code, determining the risks, the benefits, critically interpreting and implementing the code, considering perhaps different approaches, identifying others' expectations, clarifying your role, and then discussing your concerns. There is another model out there that was proposed specifically for managing multiple relationships. Now, the steps in this model encourage individuals to assess that current relationship that they are in for potential harm, assessing the potential relationship for potential harm, examining the harm if consultation services are not provided, and then continuing to obtain outside consultation if the clinic is concerned about risk. Another model is a model to help individuals manage moral conflict that can arise. In this model, of course, the first step is you encounter a conflicting situation. The next step would be to draw a line concerning what you, the BHC, is willing or not willing to do in that situation, and then finding a way to meet the needs of the patient without drawing that or without crossing that line that you drew. And then, of course, the last step would be to evaluate your steps or your actions in terms of how well you maintained your integrity. And then lastly, there is this the collaborative care ethical guidelines that were proposed by Runyon and colleagues. And essentially what they argue is that sometimes or most of the time in integrated primary care clinics, you have individuals from multiple disciplines consulting different ethical codes and having different standards of care. And sometimes these standards and codes align and sometimes they don't. And so what they propose is instead these collaborative care ethical guidelines. And they are 4 guiding principles as the cornerstone for sound ethical PCBH model clinical practice. These principles help provide a framework for interdisciplinary discussion, reflection, and analysis, and also give members of the primary care team a shared language, especially when they're trying to resolve those ethical dilemmas together. Now, one thing to consider again is that a lot of these models, in addition to this collaborative care ethical guidelines, is that they are intended to offer complementary approach to those discipline-specific ethical guidelines and not necessarily to replace them. And lastly, I said lastly in the last slide, but I meant lastly this slide. The AMA Code of Ethics, Code of Medical Ethics. as part of being a BHC, a competent BHC, working in an integrated primary care setting, it's important to be familiar and to read the AMA Code of Ethics as well, so that you can familiarize yourself with the standards that are guiding the PCPs in your practice. So if you scan this QR code, it will take you to the website to learn about those codes. And that is it. So I'm open to taking any questions now. And of course, a slide for references.
Great presentation. I actually have a question more for medical residents. So I work with a residency training program, and a lot of the topics that you brought up in terms of the difference in ethics come up a lot, and it's specifically training residents for primary care. And one of my worries is as more and more mental health is managed in primary care, especially rural areas, that doctors don't have the same view on multiple relationships. And I have actually had lots of debates with my colleagues about this that are all physicians, in terms of that the multiple relationship is a benefit and they can understand their patient better because they know them personally, and so this is something that comes up a lot. And I don't know if you have any advice on navigating that and helping residents. I mean, what I've done so far is kind of informing residents on psychology, ethics, and how that differs, but specifically for the residents to understand potential harms.
Okay, so just to kind of clarify, so you've been working with the residents to help them understand some of the complexities of like multiple relationships, or some of the benefits of managing or engaging in a complex relationship, or both?
Both. So yes, I think my concern is more, and I was more in a rural primary care practice before, where people were, managing antidepressant medicines for their niece, and things that to me seem like, oh gosh, this is a multiple relationship. But what I'm finding is doctors don't get a ton of training on that, and so I mean, I think kind of just the potential risk and benefits.
Right. Yeah, I mean, it's interesting. If we read over the AMA Code of Medical Ethics, they do have a section on treating colleagues. And so in the opening statement, I forget the exact words, but essentially they view it as, as a kind of a privilege, right, to treat a colleague, and that it kind of also reflects that they trust you, right, as a competent provider with their care. And they do acknowledge that, one needs to be mindful that it can, impair someone's objectivity. But it really states, that in a situation where it's not going to impair their objectivity, they encourage this to occur, right? So it is an interesting discussion. And if we look at our own ethical code, it also doesn't clearly say that you shouldn't. And so it really is a process of weighing the risks and the benefits of it, and weighing, whether, this could impair objectivity or not. And so it's not a clear yes or no. It really depends on the context, and that context could also change over time. And so in one situation, at one point in time, it'd be totally okay, and then that could change a few months down the road, right? But I appreciate that you're having these conversations. I think conversations like this in an interdisciplinary setting are very helpful, because I agree, sometimes they lack exposure to this. Barbara?
I just, want to thank you for this wonderful presentation, and to underscore what you're saying about interpretation of the ethical code. There has been a new ethical code being worked on for years by APA, and a group of integrated primary care folks did give input, looked at the last code, gave input. And it was very interesting meeting with folks who are working on the code changes to realize that often it's us who undercuts ourselves, that we are too rigid in interpreting, and it's not the individuals, it's often graduate programs, and especially if they're training traditionally trained therapists, people to be therapists, etc. There's a very rigid look at that code. So there's a lot more flexibility even in our current code, as you're saying, than some folks realize.
Yeah.
And hopefully in the new one, there will be as well. So thank you, Gabby. This was great.
Yeah, yeah. I do want to say, right, there's a task force that has been working on updating these ethical codes to reflect the changes in how our services are being delivered and in the settings in which they're being delivered. And there's also an ethics committee, and I recently saw a call for nominations for folks to get involved. And I think it's really important for folks who are working in these settings to serve in these roles so that they can inform these changes to improve overall care. Any other questions?
Dr. Gibson-Lopez, thank you so much. I just wanted to point out to folks who are not looking at the chat, the QR code might not be working on some phones. It didn't work on my phone, so we went ahead and added the link to the chat, the QR code for the AMA code ethics. So just take a look at that for those of you who haven't seen it. Well, let me just throw out a quick question, Dr. Gibson-Lopez, because I imagine if I'm new into this world and I hear you say something like, if you do meet with someone and then you realize they're related to this other patient that you're working with, consider connecting them to somebody else if there's going to be an issue that interferes with your ability to work with them in a pretty effective way. So I'm thinking couples, for instance, right? How would you go about having a conversation with your patient who you now need to refer someone somewhere else without saying, sorry, I'm actually dealing with your husband who's also been complaining about you, so let me go ahead and refer you somewhere else? Like, what kind of conversation do you have with your patients? What kind of conversation do you have? And to the point earlier with the PCP who wants you to see patient because you've helped them so much with their patients.
Yeah, yeah, definitely. I know that situation comes up likely more often than we'd hope. The collaborative care guidelines that I mentioned in one of the last slides really emphasizes the need for transparent communication. And so, yeah, oftentimes this conversation could be a little nerve-wracking to have. And there's a concern that if I bring this conversation up with this patient and tell them essentially that I'm seeing that other patient, there's a breach of confidentiality. But sometimes not having that conversation could be more harmful. And so sometimes the most ethical thing to do is to openly discuss that this is the situation and being transparent that in the situation, this can occur. These are some of the things that can make the care a little bit more challenging. And then providing options and engaging in shared decision making to see what they want to do. Sometimes that needs to happen in order to really provide the most ethical care in that specific situation. And yeah, I mean, that means that sometimes you need to disclose, a reason why you're asking to refer them or see someone else.
Thank you so much. Really, really great, a great presentation. And I really wish that we would have been able to offer CEs for this, but keep coming back, people, because we will have CEs in the future ones. And this had more to do with planning purposes and things. But I also want to open up the floor to Dr. Ward Zimmerman, because she had an update to give that I skipped. I skipped over a very important update. So I'm going to give Dr. Ward Zimmerman a couple minutes to give y'all an update on something.
Just really very, very quickly. One, I love this Cheers series. I think this is really great. So thank you, Yahira and Brittany, for getting this going. We have a great representation of folks here today. Hopefully many of you are active in our integrated primary care interest group. But for those of you who are not, please contact Yahira and or Brittany and find out about where your interests lie, where they match some of what we are doing here. One project that I did want to mention is that we are working on a toolkit. So under Gabby's direction, we are working on a health equity toolkit that will be made available on our Division 38 site and accessible to any member. Won't be out for another several months, but we're plugging away on it. And we would love to have additional folks to work on this toolkit with us. And it's really to facilitate increased health equity in integrated primary care where there's such promise. But of course, we don't have health equity yet anywhere. So we're going to be providing a lot of different resources and information and tools to help you to foster greater health equity in your systems. So please contact Gabby if you are interested in joining us. Good to see everybody here, or at least see the names of everybody here.
Thank you, everybody. As a reminder, this is recorded. You will be able to access this. And Dr. Gibson Lopez, it's okay if we share the slides with those who attended? Awesome. Much, everybody. My email address is on there. Feel free to reach out with any questions. Really much appreciate your attendance. Hope to see many of you in the future talks.